So Tim is going to introduce the next speaker.
Well, my guess is the next speaker needs little introduction, but for those who just arrived this morning, I'm happy to present Dr. Peter McColgan, who is the clinical science lead for the tominersen project at Roche, and he's about to unveil the much anticipated next steps on the program. Thanks.
Thank you so much for the introduction. It's great to be able to be here today and to share this information with the community. Just waiting for my slides. Okay. So I'm so pleased to be able to be at this stage where we can share with you the phase 2 dose-finding study for tominersen. Just starting with my disclosures. And before I go into the detail about the study, I want to make a point of thanking all the patients and their families for their commitment and dedication to all of the tominersen programs in the last number of years, because without their commitment and dedication, we wouldn't be in a position today to be able to move forward with tominersen. So the new study is Generation HD2. I'm going to begin with an outline of today's presentation. I'll go through the study design overview, the rationale for population and dose selection, and then I'll provide some details in terms of the inclusion and exclusion criteria, the endpoints, and the participating countries. So let's look at the study design. This is a phase 2 dose-finding study, and there are 3 key objectives: safety, biomarkers, and assessment of clinical efficacy trends. With an overview of the study, we will be looking at 2 doses of tominersen in participants with prodromal HD, that's 20 per arm, and early manifest HD, that's 100 per arm. So 120 per arm approximately, with a total of 360 participants. There'll be a 4-week screening period and then randomization. Then participants will be randomized to tominersen 100 milligrams every 16 weeks, or tominersen 60 milligrams every 16 weeks, or placebo every 16 weeks. We will have an independent data monitoring committee look at clinical, imaging and biomarker data every 4 to 6 months. Participants will be in the study a minimum of 16 months, and it will follow a common closed design. I'll come on in the next slide to explain what a common closed design is. At the end of the study, we will analyze the data, and if the data supports moving forward, there will be an optional open-label extension study. So let's look at a common closed design. If we consider the last participant in the study, they will complete 16 months. If we consider the first participant in the study, they will complete 16 months and will continue in a blinded treatment period until the last participant has completed their last visit. And this is typical of a common closed design. In the minimum 16-month period, there will be 7 clinic visits and 4 interim phone consultations. And as I mentioned, in terms of the open-label extension, that will be data-driven and will be based on finding a dose that achieves the safety, biomarkers, and clinical efficacy trends that I mentioned. So in terms of rationale for population and dose selection, I go to the post-hoc analysis for Generation HD1. Many of you have most likely seen this before. This is the subgroup that we identified in Generation HD1 where there may be potential benefit, and this is a low-age, low-cap subgroup. So this is based on a median split of age and cap at baseline in Generation HD1. Here I'm providing a summary of the data. We've provided the full-time courses before. We're looking at weeks 53 and 69. These are the last time points with treatment. We're looking at change from baseline in CUHDRS. We have blue treatment every 8 weeks, orange, treatment every 16 weeks, and grey is placebo. If we look at week 69, we can see the point estimates for the orange are above placebo, and the direction of improved outcome for cUHDRS, TFC, the direction for TFC is the other way because improved outcome is down the ways. For SDMT, again, the point estimates are slightly above placebo. It's important to say that this data isn't statistically significant and it's a post-hoc analysis. However, the consistency across these measures give us confidence to move forward looking at this specific subgroup in the new study. We also looked at this subgroup in terms of exposure. We split exposure using the average CSF tominersen concentration averaged over week 0 to 21, and we do a median split of low and high exposure. Again, we've shared this before, but we're looking at, on the y-axis, difference from placebo. So the placebo is represented by the dotted line. In green, we see low exposure. In pink, we see high exposure. So this is cUHDRS. You can see that low exposure subgroup has point estimates above placebo and high exposure. We see the same thing for TFC. We see the same thing for TMS. Again, it's the other direction. For SDMT, low and high exposure are comparable at week 69. For strip word reading, again, we see the same thing. The low exposure subgroup has a point estimate above high exposure and placebo. So putting these two slides together, this suggests that there may be a benefit of tominersen every 16 weeks in patients who are younger with less disease burden, specifically in this low exposure range. And it's this low exposure range that we target with the higher 100 milligram dose in the new study. And the 60 milligram dose is to explore the full therapeutic range. So let's look at what these CSF tominersen PK profiles look like, specifically in the low-age, low-cap population, and these are simulations. So first, looking at the 120 milligram dose from generation HD1, that's treatment every 16 weeks with a loading dose. You can see that there's an inflection point at week 21. This represents the loading dose. In the new study, we will not have a loading dose, and so you don't see this inflection point. In green, we have 100 milligrams, and again, 60 milligrams to explore the full therapeutic range. Some of you may have seen the poster from our clinical pharmacology colleagues, Yumi Yamamoto and Patricia Sanuel-Decray, and if not, you may get a chance to see it after the talk. So let's look at what these doses look like in terms of CSF mutant Huntington lowering. On the y-axis, we have percent change in mutant Huntington from baseline. On the x-axis, we have week. And again, these are simulations in a typical low-age, low-cap population. So with the treatment every 16 weeks, 120 milligrams dose with loading that we used in generation HD1, we had a maximum CSF mutant Huntington lowering of around 30%. For the 100 milligram dose in the new study without loading every 16 weeks, we have a maximum reduction of around 25%. And for the 60 milligram dose, we have a maximum reduction of around 20%. Moving on now to the inclusion and exclusion criteria. So in terms of the inclusion criteria, as I mentioned, we're looking at the subgroup we identified in the post-hoc analysis. So that's an age 25 to 50, CAP score 400 to 500, with a total motor score of greater than 6. And a study companion will be required so that we can get accurate, robust information for the total functional capacity scale. For the prodromal population, that's a DCL 2 to 3, independent scale 100, early manifest DCL 4, independent scale 70 to 100. In terms of exclusion criteria, current or previous use of an antisense oligonucleotide, including tominersen, or other Huntington-lowering therapy is an exclusion. Also because we use a lumbar puncture, antiplatelet or anticoagulant therapy is an exclusion, and also prior history of gene therapy, cell transplantation, or brain surgery. In terms of endpoints, again, these match our safety, biomarker, and clinical efficacy trends objectives. So safety, we're looking at incidence and severity of adverse events, change in CSF leukocytes and proteins, and safety MRI. In terms of biomarkers, for the primary, we're looking at percentage change from baseline in CSF mutant Huntington at 9 months. And this 9 months point is in between dosing where we would expect to see the maximum lowering. In terms of efficacy, we're looking for clinical efficacy trends for CUHDRS, non-US, and TFC-US at 16 months. So this will be a global study, and we plan to run Generation HD2 in around 15 countries. Specific study sites will be listed on the clinical trial registries once the site is nearly ready to enroll participants. So let me summarize and conclude. Generation HD2 is a study that will test 2 doses of intrathecally administered tominersen, 60 and 100 milligrams given every 4 months or 16 weeks. Every participant will receive tominersen or placebo for at least 16 months in a common closed design. And we will ask the Independent Data Monitoring Committee to review clinical, biomarker, and imaging data every 4 to 6 months. So the study will include 360 participants with prodromal or early manifest HD, age 25 to 50, CAP score 400 to 500. And it's a global study expected to run in 15 countries. With that, I want again to say a massive thank you for everyone who has helped us get to this stage, particularly patients and their families.
Thanks, Peter, for this clear outline of the planned study. I'm sure there are questions. Yes.
Thanks a lot, Henrik Zetterberg, University of Gothenburg and UCL. I would consider adding NFL in CSF and blood as a safety biomarker.
It's definitely something that we're thinking about. Yeah.
Mm-hmm. Right. Additional questions? And here, Ed, in the front. And I do have a question too. Okay.
Thanks, Peter. Can you comment on or give some idea of sort of timelines?
So the study we plan to start early next year. Yeah.
Thank you.
All right. So, Peter, the question that I have for you is, you started with testing, and I think that's the right way to do it, and a hypothesis was generated out of a post hoc analysis. Now, let's suppose this thing is working, and you have a reduction of mutant huntingtin, no safety signals. You have now constrained the population to a young population with rather rigid, rather narrow window. So how are you going to about planning a potential confirmatory study, next step, and given that you have data on a part of the population?
So I think our first objective is to confirm the signal that we've seen in the post hoc analysis, but what we would like to do going forward into a pivotal study is expand out that age range and be able to expand the CAP score as well. But I think we first need to focus on the subpopulation that we've identified in the post hoc analysis, and if we can achieve the objectives of safety, biomarkers, and clinical efficacy trends, that will give us then confidence to move forward and expand those age and CAP cutoffs.
All right. Additional questions? Well, I don't see any.
Everyone's happy.
That's terrific. Thanks, Peter, for a very clear presentation.